There we go. Okay, so at least I started at the beginning and I didn't forget for too long. So with adaptation, we're looking at how the newborn adapts to extrauterine life and um, how we're going to assess that, how we're going to determine if the adaptation is successful or if the baby needs some intervention. So some of the things that we talked about in class, or if we didn't actually meet last week or yesterday because of the holiday. So some of this information towards the end will be new information that we didn't actually discuss in class. But APGAR scoring is the way that we evaluate our babies at 1 minute of age and at 5 minutes of age, and then possibly again at 10 minutes. So the scoring system is something that you most certainly will need to know for exams now, for HESI, and also for your NCLEX. They will want to know how you're going to score that baby and what that score actually means. So the activity that you're going to give scores for is, are they moving? Are they just laying there? If they're limp and they're not moving at all, you're not going to give them any points. If they're moving around just a little bit, they may be flexing their arms and legs a little, but it's just small movements, then they get 1 point. But if they're actively moving and squirming like a normal healthy baby would, then they get 2 points. And when we talked about before, when we were talking about at delivery, babies should be mad. They should be angry. At 1 minute, they've come out of a nice, warm, toasty environment, and it is cold and they're wet, and they should be angry. So we should be getting twos on everything. A pulse, if they have no pulse, no points. Their heart rate should be over 100. What's a normal pulse rate for a baby?
120 to
What?
160.
Yeah, 120 to 160. So it definitely should be over 100. So if it's below 100, but they do have a pulse, they get 1 point. If it's over 100, they get two. Um, Grimace or reflex irritability, if they are mad and sneezing and coughing, um, they get 2 points. That's what we would expect. They've got fluid in their face. Um, they should be kind of uh, coughing. They should have fluid up their nose. So they should be trying to expel that and making a face and grimacing. So if they're doing that, and they're mad and giving you that face and trying to get rid of that fluid, then they get two, and otherwise they get one. Appearance, their skin color. We've talked several times about them being pink, like their trunk being pink, but their hands and feet being blue, and that being the 1 point that they would lose for their APGAR score. So if they're blue or gray all over, they get no points. If their trunk is pink and their hands and feet are blue, they get 1 point. But if they're completely pink all over, they get 2 points. Right here is where most babies lose 1 point. If they have a 9-10 APGAR, this is where they lost that point because they have blue hands or feet, almost without a doubt. Respirations, if they're not breathing, they get nothing. If the respirations are slow or you're having to stimulate them to get them to breathe, then they get 1 point. And if they're crying and screaming and they're mad, they get two. So you can reason out no points if they're not good or it's absent, 1 point if it's just barely there, 2 points if it's good. And then all you have to really remember is what you're scoring. Okay, so you have five points that you're scoring. These are your ranges as to how you know what you're going to do. If you have a total point of 0 to 3, you have a severely depressed baby, you're going to have to intervene immediately. And this baby is probably going to go to, well, most definitely going to go to the nursery, because you you cannot leave a baby like this in a room with a mom. Even after you've resuscitated this baby, it has to go to the nursery to be observed. A moderately depressed baby, 4 to 6, can go either way. This baby may just have a difficult start and it's going to perk right up and do fine. So just because you have a 4-6 APGAR at 1 minute doesn't mean at 5 minutes it's not going to be a 9-10. You know, it can perk right up. Babies will shock you sometimes at how quickly they improve. At 1 minute, it can be a 4 or 5, and then a couple minutes later, it's screaming and kicking and crying and looking great. The opposite can be true as well, though. You can have a baby that at 1 minute is 4 to 6 here in this moderately depressed range, and it can crash. So you can't feel secure when it's there. These babies in the middle can go either direction on you. So when you have a baby at 1 minute that's 4 to 6, you know that you may need to prepare to take that baby to the nursery, or it may perk right up and it stay with mom. So these are middle of the road babies, can go either way very easily. Babies that are 7 to 10 at 1 minute are in good condition. They will most likely at 5 minutes be a 9 or a 10. And that 1 point is usually going to be because their hands are pink or hands and feet are not pink. But these babies do very well and most certainly will stay with mom. This is just another way of looking at an APGAR scoring system. Every facility has a different chart that you put the numbers in. So you may see it like the one on the left, and you just put your number in here in this box. You may see something like this one on the right. On it, you don't really see a place to put your number. You may circle it, and then down at the bottom someplace, put a score. You may write a score in under the appearance. You may just write your number. 1, 2, 2, 2, 2, in these little boxes here, and then write your total at the bottom. So every facility has a different looking tally sheet, but you're still scoring the exact same things. And if you're a visual person, this may trigger your memory as to what you're scoring a little more so than just the chart. But APGAR scores are done at 1 minute, at 5 minutes. And if you have a low APGAR score, a severely depressed or even a moderately depressed baby, you may go ahead and rescore them at 10 minutes. Like this baby that's moderately depressed, say at 1 minute they were 3, at 5 minutes they were 6. You may go ahead and score them again at 10 minutes, and then at 10 minutes they're 9, and that would justify leaving them in the room with mom rather than taking them to the nursery. Does that make sense?
Yes.
Okay. Do you have any questions about APGAR scoring or evaluating your baby at birth?
No.
Okay. Okay. Things that we're looking for as far as a baby adjusting to extrauterine life. These are some things that we're going to evaluate, and this is kind of the wet frog as a way to remember some things that you're looking for. The W meaning wheezing. Yeah.
I've got a question.
Okay.
For the APGAR score.
You may go ahead and read.
Yeah. Sorry.
That's okay.
Yeah. For the scoring, I understand it's between 0 and 3.
Okay.
Which levels are concerning for a nurse? Is it the 0 and 1? I mean 0 and 1, yeah.
0 and 1. I'm sorry, I didn't understand the question.
Um, for the different level of scoring that ranges between 0, 1, and 2, am I right to say that 0 and 1 are concerning?
Yes, yes, 0 and 1 are concerning in every category. 0, essentially, if you did nothing, you have a dead baby
Right.
there. 1, these babies were pretty much, sometimes we can just stimulate them, meaning rubbing their back, rubbing the soles of their feet. Um, Sometimes that's enough to get them stimulated to breathe on their own. Um, but sometimes you have to intervene. You know, if the heart rate doesn't go above 100 quickly, you may have to do compressions. And if the respirations don't pick up on their own, then you're going to have to ventilate that baby. So 0 essentially is dead baby. 1 is, you know, it's going to fall into that category easily of moderately depressed. So we're going to have to be intervening here some way.
Mhm.
Minimally would be just stimulating, but we may even have to start ventilating the baby and doing compressions on that baby. Um, and
So,
hopefully that
so
would,
for something like the appearance, where the blue pink coloration is normal,
mhm.
what will I do? Like if I score it like let's say a 0, do I need to intervene? Like what exactly will that look like?
If you score a baby a 0, then we definitely would be intervening. Um, and there's something called neonatal resuscitation. It's a
Right.
whole program like CPR for
Mm-hmm.
adults, and you are trained especially in that. It's hours and hours of training. It's like ACLS for adults. That if you work in, whoops, I think we lost him.
No, I can
Did,
hear you.
oh,
Yeah, I'm still
okay.
there. Yeah, sure.
Okay.
Mm-hmm.
Um, it would be like ACLS in the emergency department or in ICU for adults. So there's
Right.
a whole sequence of events that you would follow with those babies. So, you know, you would start with ventilation and then compressions and then drug interventions um, to improve the scores. Once you start that process, you're not really doing APGAR scoring anymore. You're um, following that the guidelines for neonatal resuscitation is
Right.
what you're, I mean, it
Okay.
falls into that.
Mm-hmm.
Yeah.
Okay, thank you. That's clear.
This,
Thank you so much.
yeah, this would be more for a normal healthy baby. And at 1 minute, when you're seeing this, you know, if you're still at that everything's 0 or 1 at 1 minute, um, it's going to go from APGAR scoring. We're going to kind of abort that scoring system at that point and jump into neonatal resuscitation, and then that whole system will take over.
So once you're done with your intervention again, do I have to go back and do an APGAR score?
They probably would if the baby survived.
Right.
Yes.
Oh, okay.
But then everything is documented so closely that they would have the heart rate um, documented at 1 minute and at 3 minutes and at 5 minutes. So then you would just go back and plug in what the heart rate was and what the color was like at
Right.
five
Oh,
minutes. And, you know, at 5 minutes, they may have already given drugs um, to increase the heart rate and, you know, all of that stuff. So
mhm.
technically you could go back and do an APGAR score at 5 minutes or then again at 10 minutes, but you would have all of this stuff documented in a neonatal resuscitation chart and format. So I'm not sure. It kind of supersedes the APGAR scoring in a full
Right.
resuscitation of an infant. Yeah,
Thank you.
you're welcome. I know it gets a little confusing when we say APGAR scoring is the way you evaluate, but boy, if you've got a sick baby that, you know, would die if you didn't intervene, it kind of jumps to another level. You know. This is for the the easily resuscitated normal newborn. Okay, so if we are evaluating them, say half hour after delivery or an hour after delivery, and we're just monitoring what they look like, we're going to use the wet frog method, and we're going to listen to them, make sure they're not wheezing. A wheezing is a high-pitched sound in their airways. You can definitely hear it with a stethoscope, but sometimes you can hear it just listening to them. Just whether you're holding them or they're laying in the crib, you can hear them breathe. What kind of effort is it taking them to breathe? You might pull their blankets and their t-shirt away from their chest and look and see what kind of movement is going on in their chest. When we talk about effort here, we're talking about supraclavicular movement. Like, are the muscles around the clavicles pulling down? Are they drawing when the baby's trying to breathe? But then if you drop down here under frog, the retractions, you're going to also expose their chest and see if the rib cage is retracting, if there's intercostal retractions or retractions around the sternum when the baby's trying to breathe, meaning the muscles are just pulling in around the rib cage and around the sternum when the baby's trying to breathe. That's not normal. They shouldn't look like that when the baby breathes. Tachypnea is when the baby's breathing greater than 60 breaths per minute. What's normal respirations for a baby?
30 to 60.
Yeah. And if it's greater than 60, that's concerning. Sometimes if they have meconium aspiration, you will see rapid breathing. And that's one of your, I have a note here, I wanted to bring that up. Meconium aspiration syndrome. Tachypnea is one of your first signs of respiratory distress with meconium aspiration. So if you're noticing any breathing issues and you see that tachypnea, that's one of the things that you want to look back at. If you didn't do their delivery, look back at their chart and see if they had meconium stained fluid and think, ooh, they're breathing rapidly. That's one of your first signs of meconium aspiration syndrome. So let me check and see if they had meconium in their fluid. That's good to put those things together. Flaring nostrils. Babies, their nose shouldn't flare open when they try to breathe. That's not normal. And then we talked about retractions. Oxygenation. We look at mucous membranes to see how well oxygenated they are. And then when we were talking about hands and feet are the last things to pink up. So even if they're 12 to 24 hours old and their hands and feet are still blue, that's okay. As long as their trunk is pink and their lips are pink, then they're getting plenty of oxygen. Those hands and feet are going to be the last things to get pink. And grunting, and it's usually on expiration. When they breathe out, you'll hear that little grunty sound. It'll be like, so it's not inspiratory. It's when they exhale that you hear that grunting sound. And any of those things, if the baby's in the room with mom, would be a reason to take the baby to the nursery and have it further evaluated and check maybe it's oxygenation, put a pulse oximeter on and see what that looks like. But just at least evaluate it further because none of this is normal.
So I have a question.
Okay.
So if there was a case study and it said evaluating the baby at 10 hours, trunk is pink, but hands and feet are blue, and there's A, B, C, D, but C says do nothing but document because the baby's 10 hours old. That's the best answer?
Yeah.
Okay.
Yeah, that would be right because that's the last thing. And up until 24 hours, that's pretty normal. And again, on your APGAR score, if they're a 9 instead of a 10, it's going to be because their hands and feet are blue. So it's initially, and it can last up to 24 hours, 12 to 24 hours even. Yeah. And considered normal. So you would just document that you see it. So the nurse comes behind you and knows that it's not a new finding. You know, it would be concerning if the baby was completely pink at birth and had a 10-10 APGAR, and then at 4 hours, they were completely pink. And then at 10 hours, their hands and feet were blue. That would be concerning. But, you know, as long as we're documenting it all along, that's perfectly normal.
Yeah.
That's why the documentation is so important. Yeah. Okay. Any other questions about that?
No.
Okay.
One more question, sorry.
Okay. That's okay. That's what I'm here for.
Like how are you gonna do the APGA if God forbid, like the baby is a stillbirth? Do you still go ahead and do the APGA, or
No,
you don't do anything at all?
no. If the
Okay.
baby's born, we call it a fetal demise.
Mm-hmm.
If the baby is born dead, and there's different there's different ways that can happen. You can know that the baby, you didn't have a heartbeat before delivery, so you know that you're going to have a fetal demise, and that's already documented all throughout the chart that there's no heartbeat.
Okay.
So there would be no APGAR scoring or anything expected at that point.
Thank you.
You're welcome. Some things that we do at birth, we might hit this a little bit later, but we do our APGAR score. We do prophylaxis with ointment in the eyes. Do you remember what kind of ointment you put in the eyes?
Erythromycin?
Yes. And it's just to prevent infection. Do it on every baby. Works great. Babies are really at risk for eye infections, and it's a great prophylactic. So it's important that you remember that we use that and why we use it. What's the injection that we do at birth?
Vitamin K.
And why do we do that?
For blood clotting.
Yes, it helps prevent bleeding. Vitamin K, in babies aren't able to produce that themselves at birth. About a week later, they can produce it on their own, but it protects them for about that first week of life from any kind of bleeding issues, which is really important, like especially in a preterm baby, but we do it on all babies. So that also is important. Okay. Things that you might see on babies when you're doing that first assessment. Do you know what a Mongolian spot is?
Yes.
Okay.
If you're Hispanic or African descent, you could have these like bluish, kind of look like bruises on their back or their butt.
Yes. Anyone with a darker skin tone could have the genetics that would have the darker pigmentation areas on their, and it's usually on the back or their hips. So good. Nothing to be concerned about with them. What about an infantile hemangioma? Do you know what that is?
A strawberry hematoma. It's like a red puff
Uh-huh.
of blood cells that just puff.
Yeah. Little cluster of capillaries or blood vessels that are raised. Yeah. It's different from a port wine stain. A port wine stain are blood vessels, but they're not raised. They're flat. And just as the name of the port wine stain looks like red wine has just spilled, you know, it's just it's flat. where the hemangioma is a raised or looks like a strawberry. It's can be globular, but the port wine stain is flat on the skin. Now, there's something else called a nevus simplex. Do you know the difference between a nevus simplex and a port wine stain?
Isn't a nevus simplex just a mole?
The nevus simplex kind of looks like a port wine stain. It's a reddish, splotchy looking area. It's very commonly on the back of the baby's neck. It can be anywhere, but that's the most common spot, is like on the nape of the neck. And it looks very much like a port wine stain. Sometimes it's not quite as deep in color, but you can tell immediately if it's on the baby's hand or the baby's face and it's not on the neck. You can touch a nevus plexus and it will blanch out. It will turn white where you touch it. A port wine stain does not blanch. Okay. A nevus or nevus simplex will fade away over time. A port wine stain does not. A port wine stain is a birthmark that is there for life. Now, there's a lot of laser procedures now that are helping to remove those. But a nevus simplex fades. So by the time a child like goes to school, it's hardly even visible. It will come like in those preschool years, if they get hot or angry, they will come back. I've had children that will have them like on their forehead, and even like kindergarten teachers will say that when they're playing at recess, they'll come in and they'll have this big red spot on their forehead, and they would think they had fallen and gotten hurt, but it was actually just that nevus simplex that when they would get hot would start showing up. And there was no injury. It was just, it would get red, but it eventually just fades away, and you never know that it was ever there. And again, it's most common on the nape of the neck, but it fades and goes away completely where the port wine stain stays. Okay, those are most of the things that you see. And again, they're all benign. They're not anything that you're going to be concerned about, but they're things that you may see at birth. Okay. Nursing care. Some of the things that we're going to do, we'll just run through these pretty quickly. As with any patient, we want to make sure the airway is patent. That's going to be your most important aspect of immediate newborn care, always. Skin to skin is important. It's important for temperature maintenance. It's important for bonding. It's helpful with feeding as well. We talked about circulation and perfusion before when we went through newborn care. Body temperature, cold stress, bonding. We're going to talk more about breastfeeding in a little bit. We talked about eye prophylaxis. We talked about vitamin K. Look at make a note to look at your newborn pain scale, so you're familiar with it. And you know your vitals. We talked about that. 110 to 160 is your heart rate. 30 to 60 is your respirations. Temperature 97.7 to 99.5.
Just take you back about the heart rate.
Uh-huh.
I thought you just said it's 120 to 160. Is it 110 or 120?
Either, it doesn't matter. It depends on the book that you're looking at. 110 is on the low end,
Right.
120 to 160, some books will tell you. What I will tell you is if you have a baby that's 110, since that is low, the thing that concerns me with low babies is that if we're monitoring a baby and it's running 110, 120, that we can mistakenly pick up mom's heart rate if she's running high. And we know that moms typically, when they're pregnant, run a higher heart rate. So I get really nervous to make sure that I'm really listening to the baby and I'm not picking up mom if I'm getting 110. Okay. So there are babies that run as low as 110, and that's still considered normal. It's low. But that's the concern when I get a baby that's 110, that I'm really making sure that I'm picking up baby and not mom if it's that low. But just depends on the book that you're looking at. If you have a test question that's asking you a normal heart rate or having you determine if it's something outside of normal, it will give you something like 102 or baby's heart rate's 96. It's not going to give you 110 because a lot of books will say 110 to 160
Right.
versus 120. So it won't be anything that's controversial. It will be something like 102 or 96 or something that's outside of what a textbook's going to tell you.
Right. Gotcha. Thank you.
You're welcome. Let's see. LGA, SGA babies. When we talk about babies that are small for gestational age, we're looking at babies who are maybe from moms who have had hypertension and didn't get a good blood supply through the pregnancy. And when we're looking at large for gestational age babies, we're looking at often diabetic moms, right? What are the risks of large babies, diabetic mom babies?
CS, like sections, cesarean section.
Cesarean sections
Lac-
and birth injuries, right?
yeah, lacerations or something.
Lacerations if a vaginal delivery and birth injuries. Yes, very good. Okay. Signs and symptoms of sick babies. Lethargy, difficulty waking up. This, you kind of have to work a floor before you know what's normal with this, because after the first couple hours, babies have this sleepy period. So just because you've got a sleepy period with a baby doesn't mean it's something that you're going to notify the physician about, because that is normal with a baby after the first couple hours after delivery. So you have to be able to identify what's normal sleepy and what's lethargy. Okay. But lethargy and difficulty waking is a symptom of a sick baby, but we have to be able to identify the difference there. Temperatures above 100.4 is a concern, and that could indicate infection. So we have to look at how far out they are from delivery, and we're looking at a lot of different things. Are they vomiting? What kind of things? Where could the temperature be coming from? What was going on with mom? What do their stools look like? Do they have green liquid stools? What do stools look like from a breastfed baby?
Yellow and seedy.
Yellow and seedy, and they're kind of liquidy. So just because they have a liquid stool doesn't mean that they're sick, because breast babies do. But if it's green, that's not normal. If they've refused to eat 2 feedings in a row, that's a concern. Sometimes babies will just be sleepy through a feeding or not want to eat, but that should be an isolated incident. Decreased voids or stools. So we're monitoring how often that we are changing diapers and documenting whether they're urine or stools. and the consistency of those. So if we're seeing that instead of increasing as they should from birth over the next couple days, if you notice that they're decreasing, that's important information that we need to report. Breathing difficulties, we've just talked about all of those. So we need to know what to report. Tachypnea and grunting are two of the most important. Cyanosis, hands and feet over the first 24 hours are okay, but anything other than that needs to be reported. If they look pale or mottled, that's not normal. That's stuff that we would report. Inconsolable crying. The area that I live in, there is a lot of drug use, a lot of babies that are addicted at birth, and this is not unusual. So we know usually going in that this is going to be something that's going to happen. So we're monitoring this, and if there's a change in the baby's demeanor, then we would call. But there's already protocols in place that we are managing these babies that are addicted. So if you're noticing something different, or a baby that's a normal healthy baby has inconsolable crying, then we definitely would call. Bleeding or drainage, anything that has a foul odor or redness at the umbilical cord site or circumcision site. What's a circ site normally look like?
Kind of a little bloody for the first few days. But if you're cleaning it regularly, it still should look relatively normal.
Right. It may be red. We just clean it with water, and unless it was visibly soiled from the diaper, clean with water and then dry. But you're right. It may look a little bit blood tinged the first day or so. But if there's bloodiness, drainage, a foul odor to it, the circ site, and the umbilical cord as well, none of that's normal. So you need to call the doctor about that. And drainage from the eyes. We have treated every baby for an eye infection. So if there's any kind of discharge from the eyes, we need to report that. Okay. And talking about feeding. Okay, let's do a couple questions here. A nurse is teaching a new mother about newborn feeding. Which statement by the mother indicates a need for further teaching? I will feed my baby every 2 hours, even if they're sleeping. I should wait until my milk comes in before starting breastfeeding. I will watch for feeding cues like rooting and sucking motions. It's normal for my baby to lose a little weight the first few days. So we're looking for indicates need for further teaching.
Think B.
B.
Yes, B. The baby's nursing is what helps the milk come in. So yes, B is the correct answer. Very good. Okay. A nurse is providing discharge teaching for a breastfeeding mother. Which statement by the mother indicates that she understands the need for vitamin D supplementation? Since I'm breastfeeding, my baby doesn't need any additional vitamins. I will start giving my baby iron supplements right away. I will give my baby 400 units of vitamin D daily, starting the first few days of life. As long as I take vitamin D supplements, my baby will get enough through breast milk.
C.
Oh, B.
It is C.
C.
It is C. Yes. I will give my baby 400 units of vitamin D daily, starting the first few days of life. The American Academy of Pediatrics has indicated recently that everyone is pretty much deficient in vitamin D, almost with exclusively, unless you live in a very southern area that's exposed to sun pretty much year round. And babies need the vitamin D supplements if they're breastfed. So 400 units is what they recommend daily. Hi,
So is
Nunu.
that an injection or is it liquid oral?
It's oral liquid drops. Yeah. Yeah. So 400 units daily of vitamin D. Okay. High risk newborns. Let's see if there's anything else on feeding. Poor feeding is an indication of infection as well as temperature. So if mom's got a baby who's not eating well, um, you might suggest that they take the baby's temperature and watch for signs of infection. Okay. One other thing with feeding here. Um, what disease processes would you encourage a mom to bottle feed and not breastfeed?
Breastfeed.
I'm sorry, I didn't hear you.
Breastfeed.
If the mother has like AIDS or something.
Um, with HIV depends on treatment. That that would be dependent on her treatment plan.
How about tuberculosis?
Um, I'm not sure. The one that you definitely would not want them breastfeeding would be untreated active TB. But like hepatitis B is okay. If they have chorioamnitis, it's okay. Mastitis is the one that a lot of people, um, if mom has breast infections, a lot of people are concerned about going ahead and breastfeeding with mastitis. But the latest research says go ahead and feed and make sure the baby empties the breast that it has mastitis, empties that side. Um, that is an important factor. So um, those things that we're concerned about, especially with the mastitis, it is okay to breastfeed. Um, but untreated TB, definitely they want you to bottle feed. And HIV was a good answer, but sometimes with appropriate treatment and when the viral load is really low, they will also um, allow them to breastfeed. And I'm not sure your numbers on the viral load, if it has to be undetectable or I'm not sure what the requirements are for breastfeeding. But I know that I have seen moms who were HIV positive and have been permitted to breastfeed, but it would be the person managing their HIV that would make that determination. What other things would we do with mastitis to um, help mom besides letting the baby nurse and trying to empty the breast?
They could have an antibiotic and cold compress.
Most of the time they choose warm compresses and emptying the breast. So um, warm showers help. Um, but again, the nursing is really good for it. Okay, I think that's most of the stuff over nursing. Okay, high risk newborns now. When we're looking at a high risk newborn, we're going to look at especially these areas. And we've talked extensively about the respiratory effort that babies were making and how we evaluated that. What about hypoglycemia? If we have a diabetic mom and she delivers, what are one of the things that we're going to do for that baby to prevent it from having hypoglycemia?
You be giving it insulin or checking its blood sugar
Well, we're going to check its blood sugar,
and then feeding it.
feeding it. There you go. We're going to encourage mom to feed that baby at least every 2 hours in order to prevent it from having hypoglycemia. Because it's going to have a little bit of trouble regulating its blood sugar because mom has been a diabetic and her blood sugar has kind of been all over the place. It's been up and then she'd do her insulin and it would go down. And this baby is going to have some trouble in most cases regulating its blood sugar. So we want to make sure that it's feeding on a regular basis in order to prevent hypoglycemia. What is hyperbilirubinemia?
The accumulation of the bilirubin. I think it's a waste product from red blood cells.
Yes, absolutely. What's another name for it? What do we call it besides that?
Jaundice.
Jaundice.
Jaundice. Yeah. What does a baby look like that has jaundice?
Yellowish.
Yeah, yellowish. The skin has a yellow um, hue to it, and the sclera of the eye, the white part of the eye, will look yellow. Um, Breastfed babies have more of a tendency to have jaundice or hyperbilirubinemia because the way we excrete it is through urine and stool. And breastfed babies are taking in less volume than bottle babies. So they're excreting less volume of urine and stool early on than what a bottle baby is. So it takes a little bit for them to start excreting um, the bilirubin. So their numbers are a little higher earlier than what a bottle baby is. So you're going to see a little more incidence of hyperbilirubinemia in a breastfed baby than a bottle baby. If you have a baby who is scheduled for an early discharge, this, and they're a breastfed baby especially, this may be a reason that they may not be discharged because they're going to want to watch if their bilirubin levels are high. So sometimes they don't get to go home early because of the bilirubin levels. Okay. Hypothermia. When we immediately at delivery, what's one of the first things that we can do that helps a baby maintain their body temperature or prevents them from heat loss?
Drying them and keeping them warm.
Drying them, keeping them warm, and removing those wet blankets. That's one really quick thing that we can do even before we do the APGAR score. We dry them off and we got to get rid of those wet blankets and put dry ones on them because those wet blankets cause them to stay wet, and we want to get the blankets that we're drying them with away from them and then wrap them up in dry blankets or get them skin to skin with mom. So removing those wet blankets is the first priority in preventing hypothermia. And it has to be one of the first things that we think of to keep that baby warm. And then skin to skin is wonderful because if we put baby against mom and then cover them all up, it is so good for, like we've talked about before, for thermal regulation. It's good for bonding. It's good for nursing. It's just the perfect environment for that baby at birth. Feeding difficulties. Babies who are at risk of all kinds of health issues have feeding issues. So if they're hypoglycemic, they're not going to eat well. because they're lethargic. If they have respiratory issues, they're not going to eat well. Just think about yourself. If you have a cold and you're having trouble breathing, you don't feel like eating. So make that association. Respiratory issues are associated with feeding difficulties. Anytime you have a sick baby, feeding issues come up. So then we're looking at weight loss and all of the issues that go around that are associated with nutrition issues. Sepsis. We talked about things that indicate infection. So poor feeding and temperature. We talked about infection in their eyes and what we did to prevent that. So we're going to monitor babies for infection because preterm babies are at higher risk for infection. Babies who have had any kind of complication at delivery is at higher risk for infection. If we've had to intubate a baby, that makes them higher risk. If they've had meconium aspiration or aspirated any kind of fluid, that makes them higher risk of infection. Okay. Do you all have questions about these particular high risk situations in the newborn?
No.
Okay. One thing we didn't talk about when we talked about feeding was the cramping that goes along with it. Why do women cramp when they're nursing their babies?
Does it cause contraction of the uterus?
It does. And what specifically causes that to happen?
Is it the reduction of progesterone?
It is the release of oxytocin.
Mhm.
It's the same hormone that causes contractions when they're in labor. And they kind of feel the same as labor contractions. They do hurt. And with each baby, they hurt more. So if it's their first baby and they're nursing, it's like, this is uncomfortable. But if it's their sixth baby and they're nursing, they can get really miserable. So with each baby, the cramping and the contractions after delivery are more intense. But it's normal, and it's important that we keep encouraging them and saying it's a good thing. You know, it's the uterus getting back to its pre-pregnant condition, and it prevents bleeding. It reduces the bleeding. So we want to encourage them and make them help them to understand that it is a good thing, and we want it to happen. And we might give Motrin or something like that for the cramping, because Motrin helps with ibuprofen helps with inflammation, and the uterus is inflamed, and there's lots of fluid in there after delivery. So it is a better medication to help with pain management due to that cramping. Any questions? Do you know what a Moro reflex is?
Yeah, that's sort of the startling reaction.
Yeah, yeah. It's when they jump like they're falling, and they spread their little fingers out, and it's like a startle reflex. Yes. What about a Babinski reflex?
I think it happens on their feet when you touch. I'm not very sure, but a section of their feet, they'll tend to dorsiflex the big toe.
Absolutely.
Oh, yeah.
You have been studying, Dennis. You did spend all day yesterday in your books. When you run your
Thank
finger
you.
up their foot, their toes flare out. Yeah. A tonic neck reflex sometimes was called a fencing posture where they will put one hand, like pull one hand. I don't know if you can see me. They'll pull one hand up and the other one out, and and then they'll turn their face towards the arm that's extended, like they're fencing, like with a sword. And that's called a tonic neck. And I don't know why the tonic neck term, but I think the fencing term makes more sense because they put that arm out like they're fencing and face the arm that's extended. And what's a rooting reflex?
It's that sort of a reaction when you put like your gloved finger close to around the mouth. They'll tend to suck it or do something like that.
Yeah.
Mhm.
Anytime you touch a baby's face or cheek, they're going to turn towards that and like they're going to try to nurse. So it can be like you said, if you take your gloved finger and touch their face, they're going to try to nurse off that finger. But anytime anything touches their face, they're going to move towards it like it's mom. And that's a really good sign that the baby's going to be a good nurser when they try to do that, when they have that rooting reflex. What do you know about, I got ahead of, what do you know about methergin? What does methergin do?
It relaxes the uterine. So one of the
It
uterotonics.
it actually contracts it.
Contracted, sorry, contracted,
Yeah.
sorry. Yeah.
It's kind of like oxytocin or pitocin. We give it after delivery to a patient who might be bleeding. So your first line drug after delivery would be pitocin. And if you got a patient who's still bleeding, we may use methergin. And methergin's a really good drug. You cannot use it IV. It can cause a stroke if you use it IV, so it has to be given IM. And it's also contraindicated in patients who have hypertension. So it's, there are
Is
times
it
that
the
you can't
first
use
line
it.
drug, or you just say that pitocin is the first line drug?
The first line drug is pitocin or
Oh,
oxytocin.
right.
So that's pretty much what every patient receives after delivery to reduce the bleeding and cause the uterus to contract. But if they're still bleeding after the pitocin, most physicians will use methergin as their second medication, but you cannot use it with a patient who's hypertensive. That's a contraindication, and it cannot be used IV. So it has to be an IM injection of methergin. So a couple things that you have to remember if you're going to use that drug. What is caput? When we talk about caput on a baby, when we talked about assessing a baby, we didn't really talk about that. Is it serious?
Is that the bleeding on the top of the head near the sutures?
It is the one where the top of the head is elongated and it's just soft tissue that has accumulated fluid. And it's just from the baby's head being in the birth canal. Okay. So it looks like a little cap sitting on the baby's head. It's just a elongation of the baby's head. It's not serious.
So not serious.
Yeah, it's not serious, but it looks really awful. It looks bad. So review those to make sure you know which one follows the suture line and which one is the elongation. So make sure you know the terminology on those to know which ones you're going to monitor closely. What causes a fontanelle to bulge? A baby's
Dehydration?
continental. I'm sorry, I couldn't hear you.
Dehydration?
It will sink in if they're dehydrated.
Yeah, depressed when dehydrated and then barge when there's infection.
Yeah, it will, with dehydration, it will be depressed. And with increased intracranial pressure or bleeding inside the skull, it will bulge. So we'd rather it be depressed because we can fix dehydration, can't we? We can give fluids and we can fix that pretty easy. But with increased intracranial pressure or any kind of bleeding inside the skull, that can be very serious. So if we're going to want to see one or the other, we want to see it depressed because we can sure take care of dehydration. Okay. Okay, if we have babies that have neonatal abstinence syndrome, and what is that?
Say that again, please.
Neonatal abstinence syndrome. It's just withdrawal from mom was taking some kind of drugs, and it's withdrawal from that. What you're going to see in the baby is a very high-pitched cry and sneezing. Those are two very common symptoms that you see when a baby's withdrawing. But jot that down. It's called neonatal abstinence syndrome. Okay. If you have a mom who has been using something, whether it's drugs, alcohol, whatever, and they want to breastfeed, is there anything that's safe for them to use while they're breastfeeding?
Can they use methadone?
They can. Very good. Yeah, they can use methadone, but really there's nothing else that's safe. Even like marijuana, cannabis, definitely not the cocaine, alcohol, none of that is safe to breastfeed, but all indications is that they can use the methadone. So that would be our recommendation if a mom's wanting to breastfeed, that we get her in someplace and get her established like at a methadone clinic so she can breastfeed the baby. That's good. Do you guys have questions?
No, not for me.
Okay.
Thank you.
We've gone over your hour, but I think that you sound like you've got a really good handle on things. If you have a chance to visit the live sessions this week, some people do lots of case studies, some people do just content review. And even if you can't get to the live sessions, try to watch those recordings. I'll post them as soon as I get them. And you've got my contact, so don't hesitate to reach out if you just have a question.
Sure.
Sounds good. Thank you.
Oh, you're
Thank
welcome.
you.
You guys have a great week. Best wishes on your exam.
Thank you, same to you.
Bye.
Bye.